Welcome, everyone. My name is Lisbeth. I'm the Population Health Training Manager at the National Center for Farmworker Health. And on behalf of our organization, we welcome each of you. Thank you for joining this second part of this sexual health training series. And if you missed the first training, we will be sharing the link to that recording so that you can catch up and on any information you missed. And we are very excited to be welcoming today our presenters, Dr. Alwyn Cohall and Dr. Silvia Amnesty, who are working with us today again with this second presentation. And they are coming from the New York City STI and HIV Training Prevention Center. So I'm gonna hand it over to them, and thank you again for participating.
Next slide, please. Next slide. So we have no disclosures to share. Next slide. So I'm Dr. Cohall. I am a physician. My focus is on adolescent and young adult medicine. So I provide clinical services at New York Presbyterian Hospital, the Columbia University Irving Medical Center. We have a unique program that provides services for young people living with HIV. We're part of a designated AIDS center at the hospital. We also have sexual health clinics to provide comprehensive sexual and primary care to young people as well as adults. And we have a very unique outreach program that we'll talk about a little bit later that goes out into community settings to do screening for STIs and HIV, and then link people to care at our hospital clinic for additional services. So those programs are called Project STAY, Services to Assist Youth. I also run a program called the Center for Hope and Resiliency that provides primary care, mental health services to people coming home from jail and prison. And Dr. Amnesty works with me in that clinic. I'm involved in training with webinars such as this. This is part of the work we do at the New York STI HIV Prevention Training Center. This is one of 8 prevention training centers run by the Centers for Disease Control and Prevention to provide training and technical assistance to providers across the United States. So we're really thrilled to be able to be here today to talk to you about this important topic. I'm also involved in teaching. I teach public health students at the School of Public Health at Columbia, as well as medical students at the Bachelor's College of Physicians and Surgeons. Next slide.
So hi, everyone, and welcome. I'm so happy to be here with you. I am Dr. Amnesty, and I am an associate professor in family medicine, public health, and medical humanities. So I do my clinical work similarly to Dr. Cohall in a clinic that is a specialty clinic. It's a young men's clinic. And then we treat, we see, and we take care of young male patients with sexual and reproductive health issues, but also with any kind of medical care, since we, a lot of the times these patients do not have access to any other places for primary care. As Dr. Cohall mentioned, I also work at the Center for Hope and Resiliency with patients who are coming in after they were released from incarceration. They're coming home, and so we take care of them, make sure they're healthy, and do whatever is necessary to keep them healthy. So I also teach, and I teach like very similar to Dr. Cohall, public health students, medical students, but I also very involved in teaching my family medicine residents, and I I lead the community efforts in the program in family medicine in general. Next slide, please. So I want to say this, but briefly, we want to really thank all of the people who have been so helpful to put this presentation together. Lisbeth Gall, Gauri Nagendra, Jessica Stanky, Cindy Trong, Vanessa Lopez, and I'm sorry if I mispronounce anybody's name, and the translating team at the program for really putting this together for us. So we would really appreciate the help. Next slide. So as Dr. Cohall mentioned, this is the New York City STI Prevention Training Center at Columbia University, one of the 8 national, at the national level, there are 8 centers funded by CDC. And the centers have as a goal to provide STI or sexually transmitted infection, HIV education, and resources to clinical providers. So if you want more information, there is email there that you can use, and you can contact us if you need anything from us. Next slide. So briefly, we're going to review, since many of you were not here in the last meeting, we're going to just offer you a brief review so then we can move on. But for a more thorough review, Lisbeth Gall just mentioned to you that you can access the first webinar that we did about a month ago, and in talking about risk, STIs and HIV. So I'm just going to do a brief review so we can, continue with the slides that we have now. So today, that's the first thing we're going to do. Then after that, we're going to focus on having conversations about sex and STI HIV prevention and how we can, do that. I know many people are very uncomfortable talking about sex. So we wanted to have a conversation because that's a starter. If we don't feel comfortable doing that, then everything else really falls apart. Then Dr. Cohall is going to come in and talk about innovative strategies to provide access to education, screening, and linkages to care. And this is going to be a very interesting and important session in terms of, how can we creatively start, providing more services to our constituents, which the migrant farmer workers. And lastly, if we get there, because if we don't get there, we'll probably have to do it in a different webinar. We wanted to do talk about biomedical prevention for STIs on HIV. So this will be, hopefully we'll get there, but if we don't, we promise you that we will do this at some other point. Next slide. So I'm going to start talking about Ramon because this is one of the cases that we presented last webinar. And during the first part of the session, we talked about Ramon, 24-year-old Latinx. He had oral and vaginal sex with his partner, or just a person with uterus or a female, and then biological female, I should say. And then after that, he reported having burning when he urinates and noticed a yellow, thick discharge or fluid that was coming off from the tip of his penis and stain his underwear. Ramon, we were talking, Ramon wasn't using any condoms. But he has been with this regular partner for 1 month. And this partner is on the pill, so he didn't feel the need to use condoms. When he went and get checked and tested, he was negative for HIV and syphilis, but he was positive for chlamydia and gonorrhea. So let's do the next case, and then I'll talk a little bit about what we discussed, because the next case is, next case. Next slide. So I'm going to talk about these 2 cases together. Victoria is the partner of Ramon's partner. She's 19. She's a 19-year-old Latinx cisgender person. She's Ramon's partner, as I mentioned. She also came with discomfort during sex, vaginal discharge, which stains her panty liners, and she feels like she has a fishy smell that she didn't have before. So when we tested her for STIs, she was negative for HIV, negative for syphilis, but positive for chlamydia, gonorrhea, and trichomonas. So would you hold on for a moment for this slide, because I'm going to do a little review of what we talked about in terms of discussing chlamydia, gonorrhea, and trichomonas. As you know, those are all three are STIs, meaning they're infections that are only sexually transmitted, and they can be sexually transmitted when you have vaginal sex with someone, when you have anal sex with someone, or oral sex with someone. So usually is genital, but it's also extragenital sites can be infected. Extragenital sites meaning oral and anal. And so they get transmitted because of contact. These infections usually do not cause many symptoms. Like 70% of the cases, 80% of the cases, people don't have any symptoms at all. But sometimes the symptoms could be some of the symptoms that Victoria and Ramon are discussing, like burning when they urinate, having some discharge, this fishy smell. It could be characteristic also of trichomonas. So, so we have talked about this STIs. We talked about how we detect them, which is doing the testing, could be urine testing. It could be a swab that we can do in the oral and anal orifices, and also vaginal swab. And once we know these are the infections, then we can treat all those infections. All the infections that we're mentioning here, chlamydia, gonorrhea, and trichomonas, are treatable. We have to prescribe antibiotics. It could be an injection for gonorrhea, for example. It could be a 7-day course of antibiotic pills for chlamydia, and trichomonas can also be a one-time dose, or it could be 5 days. So all of these STIs have treatment. So then we're going to move to the next case. If we can have the next slide, please. The next case is Jason, and Jason is a 30-year-old Latinx cisgender. Is a person with penis, or a male, biological male. He is bisexual, so it means he has sex with male and females, and non-binary. So 1 month ago, he met another biological male or person with penis, and they met via an app. So they sometimes were using crystal meth, and then ended up having unprotected sex. So after that, Jason noticed he developed a rash. So he went to the clinic and he was tested. So he gonorrhea, his chlamydia, and HIV was negative, but he tested positive for syphilis. So syphilis is another sexually transmitted infection. Also can be transmitted orally, anally, and vaginally. And syphilis is, we used to say that syphilis was the HIV of the day, because it was an infection that could stay in your body for a long time and really cause many health issues. And so, but now we know that it's easily curable with penicillin. So if someone gets detected with syphilis, we can give them a penicillin injection, which is very painful, and the syphilis can be cured that way. So so it's not like HIV anymore, but it is curable. So let's go to the next slide, because I'm just talking about this really briefly. But if you have any questions, please put them on the chat, and about this STDs or sexually transmitted infections that we're talking about. Please put it on the chat, and we'll answer any questions you may have. Next slide, please. And our last case, which is the fourth and last, is Mercedes. Mercedes is a 75-year-old cisgender person with uterus or a biological female. She's a grandmother, and she brought to the emergency room by her grandson because they were concerned about her weight loss and white patches in her mouth. When they were taking the history, they realized that her husband had died 3 years ago of what they were told was cancer. He traveled back and forth for work, and then she had never had sex with anyone else. Her husband was the only sexual partner she ever had. Next slide, please. So when she went to the emergency room, they, of course, tested her for everything. They tested her for chlamydia, gonorrhea, and trichomonas. They were all negative. Then they tested her for syphilis and HIV, and she was positive for both. The white patches that they saw in the mouth is a yeast infection that sometimes people get when the immune system is really weakened. And then that's a candidiasis, is the white patches in the mouth. So, of course, her immune system was like depressed or was decreased. It was not working as well because she had, mainly because she had HIV, but also because the syphilis was another infection that she was trying to fight. Next slide, please. Yes, let's hold on here for a minute. I talk about HIV for a second. HIV affects millions of people in the US. I think it's 1.2 million living with HIV in the US. At this point in history, HIV is like a chronic condition with medications. One can be healthy and control the virus, so the virus doesn't affect your body. So the important part is that it needs to be diagnosed, which what happened, for example, with our case, she probably had HIV for a long time because she already had the patches because she didn't know she had HIV. And so once they diagnosed her, she probably was able to get in medications and she got better. So her immune system got better. And so I remember that we commented on the first session how the treatment for HIV has changed from taking like 20 or 30 pills a day to taking today 1 pill a day. So the treatment is a lot easier to follow. And I'm sure most of you have heard about HIV, but it's not a deadly disease, the deadly disease that it used to be. After we talk about STIs and HIV, then we talked about the challenges that we have in providing services to migrant farm workers, which I know you are probably all too familiar with it, with these. For example, one of the things that we discuss is how available we have resources and information for farm workers. We know that sometimes the resources are scarce and not necessarily we have all the resources that we need to reach out. Also, behaviors and knowledge of risk is important. And in this point, we mean people who migrate from their countries, they're probably alone, they miss their families. There's a lot of mental health issues there, which we can expand on that. If we get to do another webinar, we can talk much more specifically about mental health, because this is a big issue and is a big risk factor for getting STIs. People sometimes when they're depressed, they drink more, they probably use more substances to just forget or to simply feel happy. So that's what we were talking about in terms of behaviors. And also the other thing is that a lot of people do not have knowledge of STIs, and they do not protect themselves with condoms or other things because they don't really have the knowledge, even though it seems like everybody should have that knowledge, but a lot of people do not. So that's another issue. Access to healthcare, as you know, is a big issue, is probably one of the biggest issues. access to testing for STIs, for HIV, access to treatment is a big issue because most of our patients are far removed from the cities, and sometimes they don't have insurance. Some may be undocumented, and in most cases, undocumented do not have insurance to access healthcare. So that's a big issue. Clinic access, if they were having like availability or access to healthcare, then clinic access is another issue, is another level of barrier to healthcare, because as you know, your constituents, the migrant farm workers, work long hours and sometimes don't have time to go to their appointments. They can't make it to the clinic hours. And I discussed access for uninsured. At some clinics, you may have that, but a lot of clinics will not even see you if you don't have an insurance. We talked about fear of deportation and trust issues. Going to the clinic and having to interact with people who are, who potentially will report you. You get scared. You get scared that will happen. That generally should not happen. But we all have heard stories when that happens, and then so we get really afraid to go to the clinics and prefer, just not to go. Post-trauma and mental health, social isolation, drug and alcohol use. I spoke briefly about this, and of course, all these things have a lot to do with how we put ourselves at risk for STIs, especially with the trauma of like what we bring from countries that we migrate from, plus the actual trauma from the migration experience, from coming to your country to coming here for a lot of reasons. Not for a lot of you, but for a lot of the participants that we see, our constituents, this is a big issue. And so, and the one thing that I will add here, which is something that we're going to talk about a little more, is the importance of providing a safe space for difficult conversations around sexual health. We already talked a little. We talked a little bit about that last time, and this is one of the things that we're going to emphasize on when we talk about how to talk about sex, but in the context that we discussed last week, we were saying because of all these issues that people have in accessing care, and mainly, trust issues, fear of deportation, trauma issue, mental health, it is important to really provide a safe space for difficult conversations. And this is where we talked about that. That was the context that we mentioned that. Can we have the next slide, please? So think about the cases that we just discussed. Ramon, Victoria, Jason, and Mercedes. And now we're going to evaluate those cases. I'm going to give you a little bit more information about their lives, taking into account all the factors that we've talked about in terms of access to care, trauma, fear, all of these things that I just mentioned to you. I mean, like mental health. I want you to look at the cases because I gave you more information about where, like Ramon's lives, Victoria's lives, Jason's lives, Mercedes' lives. Look at these cases, look at the expanded history that I'm giving you there. And then I want you to discuss in your breakout room what the challenges that you see on providing assistance to these particular cases. What do you think happened with those cases? And what do you think, what could we have done better in terms of, like, if we see these cases like 4 months before they got an STI or 4 months before they got sick, what do you think could have been done in that time so that this could have been prevented? and not talk about just prevention, but talk about now how they engage in treatment, how they engage in, in prevention after they have these STIs. So I want you to think about all these factors that we talked about and discuss these cases and tell us what are the challenges, the main challenges and the main facilitators that you see. Can I have the next slide? I think there's something else there. Yes, okay. So this is the breakout rooms. We're gonna have you in the groups for probably 5 minutes. And then you're gonna get a case and you're gonna discuss these cases and then we're gonna come back and discuss them. Okay, so we all talk about Ramon. Ramon is the case that one of the groups got. Came to the US, was working on a farm. His family was not here with him. He came by himself. He started drinking more because he was getting sad and he was like really missing his family. He met other people. He sometimes used other drugs that made him sometimes pass out, had no memory of what happened to him. So he also didn't have a whole lot of information about STIs. So who discussed this group? What was the group that got Ramon? And can you tell us what your discussion was about? You tell us what you said. If anyone was taking notes and talking about this, and if not, I mean, anyone can really make a comment about Ramon's life and why you think he was.
Can we go to the next slide just to see the questions that the group was
okay
with?
Yeah.
Yes, okay.
So for each of the cases that you saw, why do you think these factors will be related to acquisition of sexually transmitted infections or HIV? In Ramon's case, what are the challenges in identifying and helping him gain access to testing and treatment? And what do you think we could have done earlier, not you, but anyone, if they would have I really detected or learned what was happening in his life? Then the next question is what I said. How do we prevent further STIs in his case? Because he continues to be sad and continues to be concerned and drinking just because he's not feeling well. He's probably still at risk. So how do we prevent him from continuing to be at risk? Anyone?
Any thoughts about what you all discussed in your group? And I'm sure you may have seen cases similar to Ramon in your own work.
So I can tell you in a little example that just taking my doctor hat. I mean, one thing that I would have noticed for Ramon is that Ramon was alone in this country and was not really together with his family. He was really missing his family. He's probably have like kids back home that he was really missing. And he was separated from his family because of the necessity that he had to come here and earn some money. So I think that puts him at risk. Do you guys agree? Do you think that that's something that could be impacting on your risk for STIs? Yes, someone says yes.
I think the reason why we put this case together, and all these cases are real cases. I mean, we changed the names and so on, but they're real cases. When we talk about STIs and HIV, we can't talk about it in isolation. There's a concept called intersectionality, which means that there's many times different factors that come together that enhance and reinforce risk. So, as Dr. Amnesty stated, in his case, it was isolation, it was depression, which led to alcohol use, which led to him even not thinking about or not utilizing condoms when, he had sexual relations and so on. So, one of the things clearly we need to do is treat this STI, but we also have to think about how to prevent this from happening in the future. And we'll talk about some medical things we can do later on to reduce STI risk. But we also need to think about providing support and counseling and so on for depression. One of the things to throw out to you is, what's been your experience with providing condoms to agricultural workers? Do they accept them? Do they utilize them? Do they have problems with them? I would love to hear your experiences, and feel free to share. Or you can put it in the chat if you don't want to talk.
Yeah, and it seems like this group is a little shy to talk because with Alexis agreed with yes, that isolation is a big factor, and then he was talking about how the use of alcohol and drugs is also a big factor for to enhance the risk of STIs. As Dr. Cohall says, we can't just not see the person and see the disease. We have to look at the surrounding, the context, what's happening in that person's life, so that there are certain factors that are going to put that person at risk. In the case of Ramon, is the isolation, is the loneliness, is the migration experience, because as we all know, that experience could be quite difficult. So let's talk about Victoria's case for a second. If we can do the next slide. So Victoria had a very similar, in a way, experience of trauma when she came to this country. She came with her mother from Central America. Her mother sold all her belongings to gather money and to be able to pay the coyotes to help them cross from Mexico to the US. The family could not find work at home, and they were living in extreme poverty. So during the migration journey, she and her mother faced difficulties, and they were kidnapped, and possibly Victoria was sexually abused by the kidnappers. So when they finally arrived in the US, she went to a health check at a local clinic and was found to be positive for chlamydia. So can we have the next slide? We don't have another next slide for this. It's just the questions, right? Can we have the questions back? I think you have to go forward. I'm sorry. And the next one. Okay, yes. So in this case, in the case of Victoria, now you know that she actually came from Central America. She had a very traumatic migration history. She was possibly sexually assaulted during her migration journey. Then she came here, and she was with her mother, but she was also, helping out with a lot of taking care of the kids. She hadn't really been able to deal with her own life and her own trauma from that experience, from extreme poverty and experience of migration. So can the people who discuss this case tell me what they think of these factors? How are they impacting her? And by the way, yes, somebody answered to the question about condoms. They do accept the condoms because they're free. Okay. But they also tend to have a mentally that condoms protect against all STIs. So, but they also don't like the condoms because it makes us less enjoyable. So that's what they said. So back to Victoria. Who discussed this case, and who, I mean, if you can put it in the chat, do you think that her experience of trauma puts her at risk for STIs? Her experience.
The group, but yeah, I think she has a whole bunch of traumas that's adding up, and it seems like she's carrying like the weight of the world on her shoulders.
Right. And how does that How does that, thank you for that. How do you think that affects her risk for disease? In what way? Because she's so anxious, she's so worried. She probably comes from extreme poverty, maybe education. It's not, like she's lacking formal education, all of this stuff. But how do you think this trauma puts her in high risk? Carrying
Say she's like easy prey for the kidnappers, and then since they kidnapped her, they wouldn't be thinking about the risk they were exposing her to. That
exactly.
would made it a lot easier for her to catch any disease. And since she was lacking money, so it would be hard for her to get treatment.
Right, right. Right. So and also because when you have trauma and you have all these issues, you probably have you know trauma that lives with you, and then that kind of interferes with your relationships in some way. So, we don't know how that goes, because someone can just not want to have any relationships, and sometimes people just feel like they need to have a lot of relationships. So it could affect in either way. It could also affect in a way that she can't, move on with her life. So this is what you said is really important. She ended up catching a disease because of the abuse. So that's just not only you get abused, but also you get sick. It's a very big issue.
But one of the things that's really important is to not only treat the infection, but as Dr. Amnesty was saying, treating the patient that came in with the infection, trying to get an understanding of where they came from and what had happened to them. So this is the case in which not only do we need to treat the infection or infections, because she actually ended up having several infections, but also helping her to deal with the trauma, deal with the abuse and the assaults, and helping to knit her life back together, in addition to providing her with appropriate education and support. So a lot of times having an STI is just kind of like an indication that there's a lot of other work that needs to be done.
Exactly. And I think that's really the main point, that all patients, that all your clients that come to you, there will be something that in their lives that we don't know, that may or may not be affecting them, but it's important to engage in conversation for that reason, because you get to know their lives better, and then you get these factors in their lives that probably are affecting their health. Can we move to the next case? So in the case of Jason, as you remember, he was born here. His parents were farm workers, and they were both undocumented. His father was deported when he was in school. He was young. He stayed with his mother. And during the summertime, Jason worked in the fields to make some money and help his family. He had one sexual experience, the first one that was like consensual, with a person with penis or a biological male, when he was 15 years old. He did not have knowledge of or information about sexually transmitted infections. The school did not have a sexual education program, and the adults in his life never really spoke to him about any of this. Next slide. So he had a pediatrician, but when he was about 14, he stopped getting health care because his mother was afraid to keep bringing him to the clinic and be deported because of her legal status. He had a legal status here, but she didn't. It's a mixed status family. Next slide. So in this case, what do you think? What factors interacted or interfere or affected his ability to protect himself against STDs?
Well, it seemed after he was 14, he stopped seeing his pediatrician. So from that, I guess the lack of access to healthcare and education was a proponent of him getting STIs.
Right. What else strikes you in the history that can
Oh, yeah.
be also
Also, losing his dad, again deported. That could be a huge mental hurdle for him to get over with.
Mm-hmm. Mm-hmm. That's right. There are other factors there that are super important. See if we can talk about them. What do you remember when I talk about the school not having sex education, parents not talking to him about, you know, all of these stuff about sex or about sexual education?
Yes, he lacked knowledge of STIs, and he didn't get any treatment.
Okay.
And also he didn't know if his like the person he had sexual relationships with had STIs, and if that person was treated for or is taking medicine, or like if they were protected when they were doing their thing.
Right, right. So it's all the factors that you're talking about. He had probably he didn't have a lot of information. He stopped going to the doctor when he was 14. His mother never talked to him about that. His father wasn't around. And on top of that, the school didn't provide any sex education. So he did not really have any information about STIs when he started being sexually active. So those are all factors that will put him at risk for STIs.
And that's why your role is so important, being out in the community, being out in contact with the agricultural farm workers and their families to really fill in that gap, to provide information about STIs, about screening, about prevention, about treatment, because they may not be getting it from anybody else. So you all are heroes. You all are really crucial to controlling this epidemic.
Right. Exactly. So can we go to the last case, please? Okay, so Mercedes' story is a story that, as Dr. Cohall said, this is a real story. We've seen a few times. So she came to the U.S. Her husband was a seasonal farm worker for years. He would travel to different sites to work. Mercedes stayed home and took care of the family while her husband worked in the US and sent money to the family. So then he became progressively ill and died after a prolonged illness. And she was told he had cancer, but he probably had HIV. So nobody ever told her that he had HIV. She never had other partners. It was only him, but he ended up infecting her. Can we go to the next slide? So in this case, what do you think put her at risk? What happened in this case? So she only had one partner in her life. She only had sex with one person. What could possibly be her risk factor? What put her at risk?
Her husband was a migrant farm worker who traveled.
Right. And so usually what could happen? He was having other partners, right?
Correct, yes.
Her husband don't protect herself.
I'm sorry, what was that?
Her husband don't protect herself.
Exactly. Probably because lack of knowledge, as we are talking about. He probably was also a victim of that, not having the knowledge, not having the right education, not having access to condoms or to healthcare, right? So ends up putting her at risk. But there's another factor that I think also puts her at risk. And that is no access to routine STI testing. Exactly. Because if she at least had her doctor and she was going to her doctor, they would have tested her and they would have known she had HIV and they would have treated her before she got really sick. Or maybe even before that, say your husband is having other partners, let's protect you, let's give you something so you can protect yourself against him getting any disease. So that's exactly right.
And one of the things that we do a lot of, we think about STDs and HIV as something that affects young people. And, the overwhelming burden of infection are among adolescents and young adults. That's where the majority of people who have STIs and HIV are coming from. But what we're also seeing is an increase in STIs and HIV among the older population because of some of the things we just talked about. Also, with the advent of Cialis and Viagra, people are able to have sex for longer periods of time than they were before. People are in and out of relationships. Older people are using dating apps now as well. So there's a lot of reasons why seniors can be at risk for STIs and HIV. So as we're thinking about spreading the information, providing condoms, getting people access to screening and prevention services, we got to think about the whole landscape of individuals, not just, teenagers, young adults, and adults. We got to think about seniors as well.
Exactly. And sometimes we fall through the cracks in taking care of seniors in this way because we don't imagine that this will be happening. So someone else said, yes, she trusted her husband. She didn't think he had sexual contact with other people. And yeah, that is true too. I mean, definitely there's a sense of trust when you have one partner that partner wouldn't have sex with other people, but then he was alone and he was alone for many months. And, he thought that maybe he was okay. It was okay to do that. I think he would probably never imagine that he would give that to her.
Which is the other myth, because it may be that he thought that, you only get HIV from having sex with other men. And if he was having sex with other women, he may not have been at risk, which is not accurate. And who knows, he may have had sex with other men as well. So we don't know exactly the backstory, but we do know that everybody should be screened, and not just once. They may need to be screened, several times a year, depending on their risk profile.
Mm-hmm. Exactly. So, so let's, having talked about this, I think you guys really hit on most of those things. So let's just move on to the next slide. And I think here, we talked about this already. Next slide, please. Okay. So we're gonna start talking about this topic. I think is really important. It actually is connected to what we were talking about because it's difficult to talk to people about sex. It's difficult to talk to people about mental health as well. So we were talking about how do we communicate with our patients so we know what's their context, what's their lives, what's going on with them. And then in that way, we can talk to them about sex. But talking about sex is difficult. What in your experience has been the obstacles or are the obstacles to talk to your clients about sex? What's difficult for you? Is there anything difficult, or what are the barriers that you have?
I would say talking about protection, most people believe not using protection is better than using protection. Like they don't think they have any STIs without like going to the hospital just because they don't have any symptoms.
Okay, somebody else was saying something. Thank you, Waverly. Somebody else was saying something about this. So the question was like, what's your difficulty in talking to people about sex? Do you think you all feel comfortable talking about sex? Yes, no?
Hello?
Yeah.
Wait, turn it up. Hello?
Yeah.
Oh, okay. Yes, sometimes it can be like a cultural thing.
Like a cultural
Like
thing,
something
yeah.
like a private thing, but sometimes when I'm in the field and I find it difficult to talk with the farm workers about it, I kind of try to say, you have to be not see it as a personal or cultural thing, just see it as a professional thing. And the more information you give them about like healthy sexual habits, the more it might benefit them in the long run. So that's how I kind of trick myself into passing that barrier, like that little embarrassment or shame one might have because of this topic. So that's how I do. I just put in a professional mindset.
Yes, that's really perfect, and you do that. But sometimes it gets tricky, David, because it's good you give the information and all that, but sometimes, and I tell you by experience, if we don't talk to people and we don't know their sex life, because sometimes we assume they have a certain sex life, they have certain partners and they do certain things, but sometimes we have no idea what people are, you know, what the sex that they're having out there, who the partners are. They may have a slip up. You have no idea. So sometimes it really is important to just talk about specifically what's happening, and you know, of course, given your level of comfort and given the level of comfort of the person who you're talking to. But I think this is really a great example. Like, you put your professional hat. You can't be putting your thoughts on your, you know, your beliefs in the middle of this, because, you know, it has nothing to do with that or taking care of the patient. Okay. So next slide, please. So again, we talked about this. Most of us feel very uncomfortable. I mean, I'm sure Dr. Cohall and I there was a time many years ago, we may not even remember that we may have been uncomfortable about that. Now it's kind of second nature for us to ask people about sex, and believe me, I mean, it's like people usually do not feel, if people understand that it's because we want to take care of them. That's one really important thing. They know you're coming from a place of goodness, a place of like wanting to take care of them. So they understand that, and they open up, or if they don't want to, they won't. So how do we talk about sex with our clients? So please, next slide. As Dr. Cohall was saying, very important. You are in a very special position. You are in a very privileged position with the farm workers because they trust you. They feel that they need someone to trust, and that person they trust is you. You've been there, you know them, you know what they're going through, you visit them all the time. They probably trust you more than they will trust any other professional, including doctors. So they are isolated. They do not have access to people that can provide health information. And so you become so crucially important to these people's lives. And I don't want to put all this burden on you, but you really, the work that you do makes a huge difference for them. I mean, we as doctors cannot make as much of a difference as you do because we're not there. I mean, we only can make a difference if they get to us, but how they get to us is because of the work that you do. So you are in this very ideal position to have these sexual health conversations with them and to provide opportunity for discussion, for reflection. They usually will talk to you because they trust you. I mean, I think that that's the main thing that you really need to understand. Anything you want to say here, Al?
No, I mean, I think the actual treatment for STIs and HIV is relatively straightforward. But as Dr. Amnesty was saying, you know, we can't do our work until you do yours. And they'll never get to us unless, you know, they feel comfortable with you and they get the information from you about the need for screening and prevention and treatment. So it really is a team effort.
Yes, exactly. So I'm going to give you some pointers in terms of how you can start the conversation. However, you seem to really be able to do this well from what I hear from David, but let's move on to the next slide. So the first thing is that it's hard to know where clients are in terms of what's happening with them. So that's why it's really important to talk to them, to get their thoughts on where they are and what they believe. The first thing, though, is to be aware of your own beliefs and knowledge about sexual health, and to understand that we don't always know everything, and we don't always agree with everything that we're hearing. Like someone who is having certain sexual behaviors that you may frown upon because you don't think that that's right. That's okay, because that's what you believe. But in that sense, in that moment, as David was saying, you put on your professional hat, and then you try to support that patient as much as possible, that client as much as possible, because it's their lives after all. And what you're trying to do is to protect him, not to like scold him or tell him you can't do that, that's not how it should be done. We all have our lives, and we have to understand that. Okay, so the main thing is that once you know what's happening, then you can better understand how you can help them, support them, and help them make informed decisions. Okay, informed decisions meaning making decisions with the knowledge behind it, and not just because, oh, that sounds good. Okay, next slide. Someone said this before. I don't remember who it was, but I think it's we talk about cultural. Be mindful of that, of the cultural, sexual, and gender diversity. There's a lot of different behaviors. I mean, if something I can tell you, and I'm sure Dr. Cohall can tell you, is like one of the most diverse stories for people is always their sexual stories. I mean, people is something that we all keep private, but then when you talk about it, you hear the story is very diverse. It's not most of time, or a lot of times, not what we are expecting to hear. So that's why it's important to hear the story from the person, and to address that person respectfully, trying to understand the cultural barrier, the cultural issues, the gender diversity, because some people don't identify in the way that you would see them. It's important to really take into account and ask the person, respectfully, how do you see yourself? How do you identify yourself?
And
Try
who you attracted to.
Yes, exactly.
And again, there may be synergy, there may be a link between, what they look like and who they may be attracted to. It could be completely, different. They may appear and dress a certain way, but may have attraction to, a range of different individuals. So it's not necessarily the external appearance, is who are you attracted to, and what body parts are you using to have sex? And that's the important thing, not only to talk about risk, but also when we're talking about screening, what types of body parts do we want to screen for to identify if someone has an infection or not? Because if we're only thinking about penile vaginal sex, we're going to miss folks who are having oral genital sex or penile anal sex. So we need to really be thinking about, sex in a variety of different ways. And the only way to find out about that is to have open and honest conversations with people in a confidential, private setting. So they need to feel that whoever they're talking to is not going to be, talking about their private information to other people, and that they're not going to be overheard having this kind of very sensitive conversation.
Yes, and we have some slides on the confidentiality, because it's crucially important. But someone in the chat said some people feel ashamed when they are infected and they don't seek help because of that, because they feel like other people are going to be critical of them. And this is precisely where you come in, where you assure people that that you want to help them, and because the STIs are something that need to be treated and be addressed. And you're going to make an environment, create a safe space when the person doesn't feel ashamed to tell you how they're feeling. But it's important to be honest with yourself in terms of what Dr. Cohall, in terms of what I'm saying. think of the person that you have in front of you, think of how that person identifies, think of that person who they are attracted to. And, with all of that, I think even if it's something for you that is difficult to understand, I think it's really important to listen and to try to address that and to give that person orientation in terms of how they can protect themselves and on if they need services, how can they get the services. It really,
Yeah,
really.
and that was a very important point. I mean, the embarrassment, the stigma, the shame associated with STIs and HIV is really very high in all segments of the community, all states, all socioeconomic status. But one of the messages that people need to hear is that these are very, very common infections. Millions of people get these infections every year. So, they're not isolated, they're not alone. And a lot of times they're getting it not because they are deliberately seeking these infections. I mean, they may be thinking that the person that they're having sex with is clean because they don't see any sores or bumps or whatever. But most of these infections have no signs, no symptoms. Someone doesn't know that they have it. And that's why screening on a regular basis is so important. So we want to make sure that people feel comfortable with screening and that if they get an infection, it's not because they're a bad person or a dirty person or, anything like that. It happens. Let's get this treated. And then most importantly, let's get your partners treated so it doesn't spread to other people in the community. And then let's think together. Let's put our heads together. Let's work as a team to think about ways that we can prevent this from happening again in the future.
Yes. And it's similar to thinking about our clients or our patients getting sick with the flu or getting sick with some other infection that is not so stigmatizing. Let's say they don't feel sick they don't feel ashamed to say they got the flu. So we have to treat it in a very similar way, that people get exposed to something and they get it. We don't have to question why that happened. We just really need to be empathetic, compassionate, and understanding of people's circumstances. Sometimes this is why we talked about why sometimes people are in this vulnerable situation so that they get HIV or that they get STIs. And it's important to understand that vulnerability because it triggers your compassion and it triggers your sense of empathy with that person who really ends up getting infected with something that they didn't want to get, of course. Next slide. We talked about this. We talk about this too, to provide the information. So I think it's important to talk about sex for all these things that we've been talking about. Because you may wonder, so why do I have to talk about sex with my clients? And that's for the doctors to do. Again, I emphasize the point that we emphasized before. They trust you. They trust you more than they trust us. So you are kind of the conduit for them to get to us so that we can treat them, okay? So you offer people information, you offer them support. You also even can, talk about unhealthy relationships, like they can talk to you about that. You can, just listen, and sometimes that helps people realize that they need to move on from certain relationships. And also, very importantly, you are in a great position to really talk to your clients about talking to their own partners about sexual health. What is it how can we help ourselves protect ourselves? How can we, if we are in a relationship, how can we, do something so that we don't get sick or so that we don't get pregnant if they don't want to get pregnant, all of that. That needs to be part of the conversation in any relationship. And a lot of people in relationships don't talk about that because it's embarrassing to them. So you can also teach them how to talk about sex with their partners, which is really crucially important. Next slide.
Just as a brief reminder, we have just over 10 minutes until
Yeah.
the end of the webinar.
Yeah, we're gonna be done with this portion of it, and then we'll stop. So Dr. Cohall already talked about confidentiality. Confidentiality is really important. You're talking about sex, you're not gonna be talking about sex in a group situation. You're gonna have a private space, a safe space for someone to be talking to you about this. So you have to know your confidentiality, like rules that you have at work, and then you have to discuss it with your client. Say, listen, everything that you're talking to me is confidential. I won't tell anybody unless you want me to say this to a doctor or to someone else, or you want me to help you communicate with someone. So this is really, really important for the patient to be able to open up. You have to make sure that you have an open mind, that you can listen, and you can be non-judgmental. We have been talking about this already, and there's, I can't emphasize this enough. Being non-judgmental really helps people open up to you and talk to you about what their concerns are. We talked about this again, no assumptions about a person's sexual identity or their sexual behavior. We have to ask questions. We can't assume that someone with a penis like someone with a uterus and vice versa. We have to talk to them. We have to really get to know them and ask them, what is it that, what are your preferences? What makes you feel bad? What are you concerned about? And then they will tell you. So we have to understand the key sexual messages, which is the next slide, and knowledge of referrals for access to further information or services. As I said before, you are the conduit to more services for them. Next slide. So these are, and you'll have this available. These are some key sexual messages. I mentioned this before, talk to your partners about sex. Like you can say, for example, to them, talking about sexual health with your partner is an important part of a healthy and respectful relationship. Consent, the issue of consent is a very, very big issue, okay? The fact that if I go out with you, that doesn't mean that I'm going to have sex with you. Sometimes people need to understand this. Sometimes it's important to talk to people about these issues of consent. And there's some statements like that here. And as example, you may consent to sexual activities, but you can still change your mind at any time for whatever reason, and your partner must respect your decision. Otherwise, it's sexual assault or rape. So you have to be aware of that. Consent is always an issue. Oh, she invited me to her house and she hugged me. And then that doesn't mean that she wants to have sex with you. And for the men, it's the same. So this is very important conversations to have with people. Using contraception is the best protection against unintended pregnancy. And I think people, I know condoms are really uncomfortable, but we can have that conversation about balancing risk. Okay, it's uncomfortable, and then you enjoy without condoms, but what are the consequences of that? And so help people make decisions based on those things, not just, oh, I just want to be in the moment and I just want to enjoy. Yeah, but what is that going to bring you? What is that going to cost you? Why don't you think about that in terms of like balancing the decisions that you have in your hand and decide for the one that you think is going to be more beneficial to you? Sometimes it's important to just take people out of the moment and kind of move them to think about what can happen in one moment that I don't want to use a condom, and then what can happen after that. Having regular sex health checks, which is, like we know that there are limitations to that. And the last message, key message is important, and it's important to feel unique. I have a right to feel comfortable with who you are. And that goes for you, and that goes also for your clients. Next slide. Next slide. So, no, prior. prior select. Yeah. So this is the things that we would recommend for you, and it will be helpful to, for example, go to your clients and then have free condoms, like you told me you already have. Be holistic. I mean, like, again, this is what we're trying to reinforce, that we're not just going to talk about sex with our clients, but we're going to talk about their lives. They need to understand that you worry about them overall and not just about their sexual behaviors. Promote sexual health and ensure confidentiality. Again, we talked about this. Create privacy in any way that you can. Next slide. So what are some conversation builders? And I have some examples here. For people who feel uncomfortable, sometimes you can start the conversation by saying, what if a friend of yours got an STI? How would you react? What would you say? That sometimes putting hypothetical questions or hypothetical scenarios can really help the person open up, like we did today with their cases, even though those cases are real, but for you were hypothetical because there were people you didn't know. Ask open-ended questions, like, tell me what your concerns are. What are you worried about? What do you know about STIs? What do you know about HIV? You know, questions that are not yes or no, but questions that they have to elaborate and they have to talk to you about. Know your local services and endorse them to people. Use a strategy of modeling information seeking behavior, meaning if they ask you something that you don't know, just say, okay, I don't know that, but let's look it up together. Let's see what we can find. Always make sure that after you have that kind of interaction with someone that is like, feels more like a little bit more intimate because you're talking about things that are very confidential to someone, make sure you check back with them and say, how was that conversation? Was it helpful to you? Is there anything else you want to continue talking about? So that kind of thing. Next slide.
And I think the thing that's really important is repetition, repetition, repetition. And also thinking about ways to provide information in different ways, not only verbally, but by providing written information. And we'll talk about it in the next webinar, you know, if they have access to online platforms to do that as well. As we've talked about with several of these cases, there was a lack of formal education. So there may be issues with literacy. And even if someone has had formal education, there may be issues with health literacy, the ability to understand and utilize health information. So we need to be really creative in how we get information to clients, using pictures, using diagrams, using videos. And as we said before, you know, repeating, you know, the messages frequently, and then asking them to repeat it back to you, you know, so that you can check to make sure that they understand what you said accurately. One way of doing it is to say, okay, if you were to explain this to a friend or a peer or someone in your family, how would you describe this? How would you explain this? And then as they are relating the information, you can then check their comprehension and then address any areas of misinformation that, you know, they said.
Yes, exactly. And I think that those are extremely important points, because sometimes we think people are understanding us, and one way of understanding,
They'll nod their heads and say yes, yes, yes.
Yeah. And then when they say, what did I tell you? Oh, I don't know. Yeah, so it's important to the feedback that you get when you ask that question is really important. So after the discussion that we have, do you have, and this is all for all of you, do you have any new ideas on how to talk about sex? Is there anything here that is helpful to you?
Or any roadblocks that you've had in talking about sex that we can kind of brainstorm together as a group. You know, this is really a learning opportunity, a learning community. I mean, there are many folks who've had very good experiences in addressing these issues. So we'd love to hear from all of you.
Yeah, and we really have 3 minutes, so I would like to, if possible, dedicate those 3 minutes to hearing, for us to hear what you have to say, what your concerns are. You can type it again if you don't want to say it to the group.
And, and again, we're talking about this in a clinic setting, which is very traditional. But in the next webinar, we're going to be talking about how we do it in the field. We do it in outreach and community settings where, we don't have a hospital room, behind us. So, the conversations are really the most important thing. And the bedrock of the conversation, as Dr. Amnesty was saying, is developing a rapport, making that person feel comfortable, ensuring privacy and confidentiality, letting them know that you are really there for them and that nothing that they say, you're going to look down on them or embarrass them because of, what their experiences or their practices have been. And that's so important to getting that information. And again, the open-ended questions is really important. Letting them talk, letting them tell their story. You may be the first person ever that has heard this information. And then you can help them do something with it by getting them to the appropriate clinical resource for additional evaluation. And we're going to talk about perhaps some strategies that you can do for screening folks for STIs and HIV in the field at the next webinar.